So these are the spec points that we'll be talking through today. So we'll be covering bits about the GI tract, so IBD, Crohn's, food poisoning, the liver, the gallbladder, and various pathologies affecting each of these different organs. So I'll get started. Okay, so starting off with IBD. So there are two main types of autoimmune IBD, and these are Crohn's and UC. And as you probably already know, the presentations are quite similar, and the investigations we do to diagnose them are also quite similar, but you can distinguish them based on the histopathology and also the actual GI symptoms. So, for example, in Crohn's, perianal disease is kind of a major indication that it's Crohn's and not UC. So, going into Crohn's in a bit more detail. So, Crohn's tends to present a bit more insidiously than UC. So, it normally presents with abdominal pain and diarrhea. So, the diarrhea can be with or without blood and mucus, and it typically goes on for, a period of weeks or even months, and then it tends to be diagnosed. And like I said before, perianal disease is a major feature of Crohn's. So if you see that in the question stem, then you'll be thinking Crohn's immediately. So this is anal fissures, abscesses, and fistulae. So fistulae are kind of abnormal connections between two epithelial surfaces. And all of these conditions are incredibly painful. So they might not directly say in the question, this person has an anal abscess. They might say they have extreme pain when a DRE was conducted, and that would kind of lead you to think that there's something wrong with the anus and that kind of area, and that leads you to think Crohn's. Um, it also has systemic features, which include fever, weight loss, and anemia. So if you're taking a history for someone that's got kind of diarrhea, 5, 6 times a day, you'd also want to be asking about these symptoms because they are quite important. So weight loss because your GI tract is inflamed, so you're not going to be absorbing nutrients as well, and you'll have malabsorption, and anemia because you have blood in your stools, so you're losing blood. And with IBDs, you have this classic rash called erythema nodosum, and that's the kind of you might have seen pictures of it. It's kind of purpley, bruisey rash that appears on the shins, and it's due to inflammation of the subcutaneous fat. And you also see erythema nodosum in TB and also in sarcoidosis as well. So it's not like specific to IBD. Okay, so moving on to the histology. So Crohn's is discontinuous, which is really important for you guys to remember. So you'd see skip lesions, and that leads to a cobblestone appearance of the intestines, as you can see in this section and this diagram here. You have that cobblestoney appearance, and that's due to normal areas of bowel, kind of next to areas of really edematous, inflamed bowel, and that's why you have that cobblestoning. And Crohn's can affect anywhere from the mouth to the anus, but the most common areas affected by Crohn's are the terminal ileum, which is like the thing, like that's the common question, and that's just a fact you need to remember. And importantly, B12 is absorbed in the terminal ileum, which is why a lot of people with Crohn's also have a B12 deficiency, and that's something you can look for in a blood test. Okay, so these kind of summarize some of the features we mentioned before. So you see fistulae and strictures. Also, the inflammation in Crohn's is transmural. So you see full thickness inflammation of the bowel wall, whereas in UC, it's more superficial inflammation. And that's another big thing that differentiates both of them. And Crohn's is also granulomatous, which is probably why you see the erythema nodosum rash, because you see that in other granulomatous conditions as well. Okay, so moving on to UC. So UC normally presents in your teens and 20s, and smoking is interestingly protective for UC. So it has a bit more of an acute onset, and it normally presents with a lot of bloody diarrhea. So, can be up to, 6 to 8 times a day. So really quite extreme. And also abdominal pain and mucus. UC is also associated with this condition called PSC. That's something we'll talk about a bit later. Okay, so the histology. So UC is continuous. So it starts in the rectum proximally and it extends backwards into the colon, but it tends not to go past the ileocecal valve. And the features are kind of superficial inflammation and ulceration of the bowel and a granular mucosa, as you can see in the picture. Um, and you also see crypt distortion, which are here, and also a lymphocytic infiltrate within those intestinal crypts as well. Okay, so here are some investigations that you'd want to do if you suspected someone had any kind of IBD. So, start off, you'd want to do a simple blood test. So, you'd be looking for a raised CRP and ESR. Also, anemia, as we talked about, they're, losing a lot of blood in their stools. And low vitamin B12 because B12 is absorbed in the terminal ileum and that's affected in Crohn's and also low vitamin D as well, just general malabsorption. You can also do fecal calprotectin as well, so that you take a stool sample for that. And the definitive diagnosis, so these are kind of useful investigations that might lead you to kind of think more down the lines of IBD. But if you want to properly diagnose and differentiate between Crohn's and UC, you definitely want to do a colonoscopy because then you can take a biopsy and look at the histopathology. So, like I said before, Crohn's, you'd see skip lesions. And importantly, you can't do a biopsy in patients with severe colitis because there's a risk of toxic megacolon and that could perforate. So, you'd want to do a flexi sigmoidoscopy instead. Okay, so toxic megacolon is what I talked about just now, and that's what it looked like in an abdominal x-ray. And we have mentioned these. They also increase your risk of colorectal carcinoma. So that's something to be mindful of when in like the long-term management of people with IBDs. Um, we have covered these. So yeah, PSC. And also oral aphthous ulcers are something you see in Crohn's. So that's why, when you do an abdominal exam, you look in their mouth because you're looking for those ulcers because that can signify underlying Crohn's. Okay, so treatment. You don't really need to know much treatment for lab med, but it's just good to kind of understand treatment in general if you're on the wards or something. So, main treatment, immunosuppression, it's an autoimmune disease. You treat it by immunosuppressing them. So, you'd give them steroids acutely, and in the long term, you can give them non steroidal immunosuppressants. So, mesalazine, azathioprine, very common. Also, new biologics like infliximab can also be used. So, surgery tends to work better for UC because, as I said before, it's continuous. So you can just cut out the section of bowel that's inflamed, and it can be a cure in some cases. It tends not to work as well for Crohn's because it's discontinuous and quite patchy. So you can't really go in and chop up all the bits of bowel that are inflamed. Okay, so now we're moving on to diseases of the biliary tree, of which there are quite a few. So get started on those. So this is quite a useful diagram. So I think for understanding these kind of cholecystitis, cholangitis, all of those, understanding the anatomy of the biliary tree and the gallbladder is really important. So yeah, the cystic duct, which drains bile from the gallbladder, meets the hepatic duct, and together they make the common bile duct, which meets the pancreatic duct, and they drain into the duodenum. So depending on where the stone is in this tree, that changes the symptoms and the presentation that you'll be considering. So, just a rough kind of summary before I go into each condition in more detail. Cholelithiasis is simply the presence of stones in the gallbladder. The stones aren't infected, the gallbladder isn't infected, sorry. So there's no kind of fever, no raised white cell count, but there can be pain, so biliary colic, if the stone kind of obstructs and the gallbladder is contracting to kind of let it pass. So next one is cholecystitis. So this ends in itis. So itis. So you're thinking inflammation. And because it's inflammation, you'd see a fever and you'd also see a raised white cell count. And this is where the stone moves out of the gallbladder and it gets stuck in the cystic duct. So you'd see it also be Murphy's sign positive. Murphy's sign is where you press down on the right upper quadrant and you ask the patient to take a deep breath in. And as the liver and gallbladder move up and hit your hand, then the patient would experience pain if it's positive. Okay, and moving further down the biliary tree, we come to choledocholielithiasis. And this is where the stone has moved and it's now stuck in the common bile duct. And because it's in the common bile duct and not either of these ducts, you have an obstructed flow of bile. So this would cause obstructive jaundice, which is quite important. And you'd also have deranged LFTs as well. Okay, and you wouldn't see a fever or leukocytosis with choledocholielithiasis. And finally, we come to cholangitis, which presents the most kind of severely with the most derangement. So we'll talk about Charcot's triad and Raynaud's pentad a bit later, but you'd also see fever and leukocytosis here because it's a kind of infection, inflammation of the entire biliary tree, and also deranged LFTs and raised alk phos. And here's a useful diagram for you guys. So gallstones, very common. I think a lot of us do just have gallstones, but they're not causing any problems. Risk factors include fat, female, and 40, the four Fs or three Fs. And that's something that's quite useful to remember. So if you see these descriptors in the question stem, you'd be thinking gallstones. And you also have rapid weight loss as another main risk factor, and certain drugs like thiazides and ceftriaxone as well. If someone has conditions like sickle cell anemia, where they have chronic hemolysis, that predisposes them to pigment gallstones as opposed to cholesterol gallstones. Okay, so gallstones, like I said before, are normally asymptomatic, but they can lead to biliary colic and the various other conditions that we'll now discuss. Okay, so biliary colic is kind of colicky abdominal pain that occurs in the right upper quadrant, and it comes and goes, and it tends to be worse after you have a meal, and typically a fatty meal. So kind of roast dinners like fish and chips, all those, they make biliary colic a lot worse because they stimulate the release of cholecystokinin, the gallbladder is contracting, and that's what's causing the pain. So biliary colic occurs as the neck of the gallbladder or the cystic duct is obstructed by a stone. And you would want to do some bloods to investigate that first. So you would check for CRP, ESR, bilirubin, and if there's no kind of inflammation, these won't be raised, and if there's no obstruction, you won't have a raised bilirubin. But just kind of to rule out other pathologies, you'd want to do bloods first. And if you do an ultrasound, you'll see a picture like this. So you'd see stones and also thickening of the gallbladder wall due to inflammation. Sorry, not for biliary colic, but for the other conditions that actually cause infection, which we'll come on to later. But yeah, for any kind of gallbladder related pathology, ultrasound is always the answer. That's your first line investigation because it allows you to quickly and easily visualize the gallbladder and stones. Okay, so cholecystitis. So cholecystitis is where the gallbladder becomes inflamed, and the patient is going to be unwell, normally have a fever, right upper quadrant pain, they'll be Murphy's sign positive, and they'll also have nausea and vomiting usually. And you'll have kind of lymphocytes, neutrophils invading the wall of the gallbladder, which is why we see an increased thickness on ultrasound. And that wall hypertrophy is what we're looking at for as our clinical sign. So on ultrasound, you also see radiolucent cholesterol stones within the gallbladder, and the management is just removing the gallbladder. So that tends to be done after after the inflammation's calmed down. So you manage, you give them antibiotics, etc. first, and then once the inflammation's reduced, then you take out the gallbladder. Okay, so Murphy's sign, we've talked about, and yeah, I think I've said all of that before. Cool. So cholangitis is inflammation of the biliary tree, and it's also known as ascending cholangitis. So it can be characterized by Charcot's triad, but it doesn't necessarily need to have the presence of all three. So Charcot's triad is fever, right upper quadrant pain, and jaundice. So if you see the three of these being mentioned in the question stem, you'd immediately be thinking cholangitis and also sepsis. So ascending cholangitis is a very serious condition as it can rapidly progress to biliary sepsis. So you'd want to be thinking about starting your sepsis 6 in terms of management, giving, fluids, fluid resus, also antibiotics. So it doesn't necessarily have to be IV Coamox. It varies depending on the trust guidelines. And if there's a lot of pus and a collection, then you'd want to be thinking about surgically draining that first. Okay, so this is a summary table. So yeah, cholangitis, you'd see jaundice because the flow of bile is obstructed. You wouldn't see jaundice in cholecystitis, and that's a useful way of differentiating the two of them. And biliary colic, the only kind of presentation would be right upper quadrant pain, typically after meals. Okay, so here's a question for you guys to think about. Um, I'll let you have a read, and I'm not sure how to do this. Maybe if you guys want to put it in the chat, you can. If not, just, think about it, and I'll go through the answer with you. Give you a few seconds to have a read. Okay, so the answer to this question is pigment gallstones. And why is it pigment gallstones? So, for lab med, every kind of feature in the question stem is, I think, relevant to the case. I don't think they put in distractors for you. So, Ghanaian man with persistent right upper quadrant pain, which is worse after meals and is now painful all the time. And this is a kind of main giveaway, the occasional severe pain in the limbs. So, especially after exercise. So, you're thinking vaso-occlusive crises, and this kind of bit suggests some kind of stones in the gallbladder. And looking at the bloods, you have raised retics and hyperbilirubinemia. So that would suggest hemolysis. So based on kind of this entire clinical picture, you'd be thinking sickle cell. And you also have no splenomegaly. So in sickle cell, you'd have autoinfarction of the spleen. So the spleen would not be enlarged. So yeah, pigment gallstones due to the chronic hemolysis of sickle cell is the answer to this question. Okay, so now we're going to move on to pancreatitis. So pancreatitis is a very serious condition, and it's where there's inflammation of the pancreas, which leads to the release of enzymes and the autodigestion of the pancreas as well, surrounding kind of tissues as well. Patients can be very sick with pancreatitis and deteriorate rapidly, but the management is typically just supportive, so fluids, oxygen, etc. So, in terms of clinical presentation, the main exam stem features of pancreatitis are severe epigastric pain that radiates to the back. So this is pain above the umbilicus, and they normally do say it radiates to the back. So that's your kind of main giveaway. This is normally accompanied by nausea and vomiting. You also have guarding and rebound tenderness as well. So when you press down on the abdomen, it's more painful when you remove your hand, and you'll notice that the abdomen, the muscles are all contracted because it's so painful. They don't want you to kind of go near their abdomen. You also see these two clinical signs. So Cullen's sign is around the umbilicus, as you can see here, and Gray-Turner's sign is bruising of the flanks. So these are due to retroperitoneal hemorrhage, and you can remember this because Cullen's sign is like a C around the umbilicus, and Gray-Turner is 2 words, and you have 2 flanks. That's how I remember it. And if you're thinking about chronic pancreatitis instead of acute pancreatitis, you'd see more calcification on a CT scan. Okay, so you have to know the causes of pancreatitis, and that's the classic I get smashed. I would say the main ones are gallstones and ethanol that you have to remember, but also there are some other important causes. So you'd want to be thinking about hypercalcemia as well, hypertriglyceridemia, also iatrogenic, ERCP, the main management for biliary obstructions by gallstones, but that can also irritate the pancreas in the process and cause pancreatitis. And there are other kind of rarer causes like scorpion stings and stuff. But yeah, gallstones and alcohol are what you want to be thinking about first. Okay, so if you suspect someone has pancreatitis because they come in, they've been vomiting and they have abdominal pain that radiates their back, you'd definitely want to do serum amylase and lipase because these are pancreatic enzymes and they'd be massively raised if you did have inflammation of your pancreas. Also, raised CRP, ESR, and blood glucose can go up or down, so it's not very kind of accurate predictor. Management, like I said before, is supportive. So pain relief, fluids, oxygen, and I think antibiotics in some cases. Okay, moving on to diarrhea and gastroenteritis. So this, unfortunately, is just something you're going to have to memorize. There isn't much kind of logic or reasoning to it. I think it can help to put them into similar classes and remember them in terms of their onset of action. So ones that make you sick faster, ones that take a bit longer, and ones that cause kind of bloody diarrhea. Um, but yeah, it's just a lot of memorizing, unfortunately. So start off with viral gastroenteritis. There are two main ones. So if it's children, so for example, if it's like they've been to like a nursery and the entire nursery is sick, then you'd be thinking rotavirus, but children are vaccinated against rotavirus now, so the incidence is a lot less. Also, norovirus is more common in adults. So if you see an entire ward being closed because of some kind of viral gastroenteritis, you'd be thinking norovirus. And to diagnose that, you'd want to do a stool PCR. And the treatment for this is just supportive, so fluids, oxygen, etc. Okay, and then moving on to traveler's diarrhea. The most common type of traveler's diarrhea is ETEC, so that's E. coli. There are many different types of E. coli, so ETEC, EHEC, EPEC, EIEC. They all cause different forms of like food poisoning diarrhea. So yeah, it's one of those things you're just gonna have to learn. And the diarrhea tends to be watery. Another thing that causes watery diarrhea is cholera. So this is like described as rice water diarrhea. Also, Shigella is another cause of traveler's diarrhea, but that's quite different from your ETEC and your cholera because the diarrhea tends to be bloody, like salmonella as well. Okay, and also another cause of traveler's diarrhea is amoeba. So amoeba has quite kind of characteristic features. So you'd be suspecting amoeba in someone who has watery diarrhea, and it can also present with a liver abscess, but that might be months after like the initial episode of diarrhea. So that the liver abscess doesn't necessarily need to be acute, and you'd want to diagnose it using using serology or stool culture, and it's treated with metronidazole. And giardia is another cause of traveler's diarrhea, and it's also treated with metronidazole, but it has quite different symptoms. So it tends to cause bloating, and the diarrhea is also quite foul smelling. So if they mention those in the question stem, you'd be thinking giardia. Okay, and typhoid is caused by Salmonella von typhi, and it's more commonly seen in people who've recently travelled from Southeast Asia. It can present with constipation, abdominal pain, and a rash. And the rash you get in typhoid is this kind of pink, spotty rash on the abdomen. It's called a rose rash, but I think it's actually seen quite rarely in clinical practice. And with typhoid, you'd be really worried about intestinal perforation as well. So if they ask you what a complication of typhoid would be, perforation. Okay, so moving on to food poisoning. So food poisoning can be characterized into having either a preformed toxin, which has a faster onset of action, and a toxin that's formed in vivo. So the ones that have a preformed toxin are Staph aureus, Bacillus cereus, and botulinum. So Bacillus cereus is the one you get from reheating rice. Classic, like the medical student heats rice up and they, 6 hours later they have they have, diarrhea and are not feeling so good. So the answer to that would be Bacillus cereus. And Staph aureus is more like barbecue scenario. So these all have like classic kind of giveaways in the question stem. But yeah. Okay, and for toxins formed in vivo, that would be cholera and C. diff as well. So these are the ones that cause invasion, and because they invade into the wall of the gut, they cause bloody diarrhea and a lot of inflammation and tend to present a bit more severely. So that's Campylobacter, Shigella, Salmonella, E. coli, but the enteroinvasive and enterohemorrhagic forms of E. coli. And to diagnose, like we've talked about before, you'd want to do a stool PCR and or a culture. Um, and important complications to think about. So with Campylobacter, that increases your risk of getting Guillain-Barré, peripheral nerve paralysis. So if you see that, you'd be thinking of Campylobacter infection. Okay, and finally, coming to EHEC, especially EHEC strain 0157, this causes hemolytic uremic syndrome, which you might have covered in hematology. And this, it has a classic presentation. It's more common in kids. You can get it from animals. So if the kid's been to a petting zoo recently, or if if you've had any contaminated food, and it presents with bloody diarrhea, as well as anemia, thrombocytopenia, and renal failure. So it's one of the macroangiopathic hemolytic anemias, MAHAs. It's one of those, and that's why you see the anemia and the thrombocytopenia. You can't give antibiotics if someone has HOS, but you are meant to give supportive care. Okay, so finally, it's quite a long slide. Quite busy. Sorry about that. So last one is C. diff. So C. diff is an exam question classic. Um, the risk of getting C. diff is massively increased by taking antibiotics. So there are some antibiotics like clindamycin that massively increase your risk of C. diff. And diagnosis is ELISA or PCR for the toxin in the stool. And it's very easily spread and it's just very unpleasant. So yeah, it's quite tricky to get rid of. And you need to give them vancomycin if they do have C. diff. And complications of C. diff are toxic megacolon and intestinal perforation. Okay, and that is kind of a summary slide of everything you need to know. Is there anything I haven't mentioned? No, yeah, I think that's fine. So this is quite good for your own notes and revision. Okay, so we have another question. So I'll let you guys have a read and think of the answer, and then I will talk through it. Okay, so the answer to this question is Giardia. So looking through it, they've recently been on a trip. So foreign travel is a risk factor for Giardia. Also, drinking contaminated water as well. They mentioned the diarrhea is mild and watery, so that is one of the features of this condition. And yeah, I think those are the kind of main giveaway features. It's not bloody diarrhea, it's just mild watery, and there's a travel history. So unlikely to be rotavirus, he's 29. Shigella, bloody diarrhea, Vibrio cholera, not likely. It's not endemic to the area that he's been to. So I would be thinking Giardia, and yeah, like we talked about before, stool microscopy and PCR to diagnose and treat it with metronidazole. Okay, another question. This one's quite straightforward, I think. So the answer to this is Barrett's esophagus, which is this. So here's a normal esophagus, and here is Barrett's esophagus. As you can see, there's kind of changes to the mucosa on endoscopy. It's kind of this like velvety appearance. And the pathophysiology of Barrett's is this. So it's metaplasia of the lower third of the esophagus, and it occurs due to constant irritation. So if you have constant reflux, then it irritates the lower part of the esophagus, and the squamous epithelium is then replaced by columnar epithelium. And this is a kind of adaptive change because the lining of the stomach is columnar, but it's not protective and it can lead to adenocarcinoma. And this is the kind of cellular progression. So this is quite important for your exams. So metaplasia is the initial change that occurs. That's the change from one adult cell type to another adult cell type. And then you have dysplasia. So dysplasia is abnormal cell growth, and neoplasia is uncontrolled cell proliferation and growth. So this is precancerous, and this can be benign or it can be cancerous, depending on the invasion. Okay, so what are the main risk factors for Barrett's esophagus? So it tends to be more common in males who are over 50 years old, Caucasian, and if they're obese. Also, smoking and drinking massively increase your risk of Barrett's and esophageal cancers, as well as family history. Okay, so like I said before, it has a pink velvety mucosa appearance on endoscopy, like this and this. It's a bit more severe. Okay, and moving on to other types of upper GI cancers. So you also have squamous cell carcinoma, and this has a different appearance. So flat squamous cells, primitive basal cells, ulceration, and the risk factors for this are smoking, drinking, achalasia, as well as these other rarer esophageal conditions. Okay, yeah, and this is quite an important distinction. So, upper two-thirds of the esophagus, squamous cell carcinoma, and lower third is adenocarcinoma, and that's due to the exposure to like different irritants. So, lower third is exposed to acid from the stomach, upper third is exposed to all of these factors we've just talked about. Okay, so we've done the esophagus. We've got quite a lot to get through. I apologize, it's quite fast-paced, but yeah, the notes are here, and you guys can, if there's an area that I kind of went through too quickly, then you can ask me at the end, or yeah, you can go through the notes in your own time. Okay, so moving on to the liver. So if you have to interpret LFTs, there are a few kind of main features to bear in mind. So ALT and AST, if these are raised, then that's indicative of damage to the hepatocytes. So ALT is specifically produced by the liver cells. AST is a bit more non-specific, so it's produced by the liver, the heart, and other muscles as well. So if these are high, that indicates hepatocyte damage, and they tend to be raised in either like acute hepatitis, so after like a binge drinking episode, or in other types of hepatitis, so hep A, B, C, D, E, viral hepatitis, essentially. Okay, and then moving on to ALP, or alkaline phosphatase. Alkaline phosphatase is produced by various sources in the body. So if you're not sure where it comes from, you'd probably want to do an isoenzyme analysis. It can be produced by the liver and the bone mostly, but it can also be produced by like the placenta and yeah, various other sources. So if ALP is high, then you're thinking more along the lines of obstructive jaundice and damage to the biliary tree due to obstruction. So this ALP is produced by cells of the biliary tree, and it indicates yeah, blockage instead of hepatocellular damage. Okay, and also albumin. So albumin is a protein made by the liver, and low levels of albumin indicate chronic liver dysfunction because that means that the synthetic capacity of the liver is reduced, and it's more of like a long-term chronic picture. And albumin is useful. So the liver also produces clotting factors, but albumin's more useful because it has a longer half-life of around 20 days. So yeah, that gives you a fuller clinical picture. Okay, and bilirubin as well. So with bilirubin, you have to be thinking about prehepatic, hepatic, and posthepatic jaundice. And I think this is covered quite a bit in LabMed. So prehepatic jaundice is your hemolysis, Crigler jars, Gilbert's, all of those. So that's where the bilirubin isn't being conjugated properly, or drugs like rifampicin as well. And then you have hepatic causes of jaundice. That's due to dysfunction of the actual hepatocytes themselves. So hepatitis, cirrhosis, conditions like that. So conjugation has happened, but it's just not enough because the hepatocytes are damaged. And then you have post-hepatic jaundice, which is typically due to obstruction. So post-hepatic jaundice is normally caused by, for example, like cholangiocarcinoma, pancreatic cancers, and various other things that like inhibit like the outflow of bile, and that causes raised bilirubin and jaundice. Okay, so if ALT is greater than ALP, then you'd be thinking more along the lines of hepatitis. Okay, and this is a diagram of the process through which bilirubin is conjugated. So it's quite a long process. So you start off with unconjugated bilirubin, which is carried in the blood bound to albumin. It's taken into the hepatocytes, and it's unconjugated by the hepatic enzyme UGT, I think, the one that goes wrong in Gilbert syndrome, and then that is transported through the biliary system to the small intestine, and it's broken down by various bacteria into urobilinogen and excreted in the feces as stercobilin, and that's what gives feces the classic brown color. A part of that urobilinogen, however, is reabsorbed through the portal vein, and it goes back into the systemic circulation, and it's then excreted via the kidneys as just urobilinogen in urine. So if you have an obstructive picture, then that could give you pale stools and dark urine, which is can classic in exam questions and indicative of some kind of obstruction. Okay, so this is another question, and these are the bloods. So if you saw this, what would you be thinking? Okay, so you have jaundice and elevated bilirubin. You also have elevated ALT and AST. And like I said before, if you have disproportionately high levels of these two enzymes compared to ALP, you'd be thinking more along the lines of hepatitis. So this sounds like some kind of acute hepatitis, which is what we're talking about now. So, causes of acute hepatitis. Normally, hepatitis A and E are acute. So I remember that like A and E, acute cause. And B can also be chronic. So that's not specifically acute. Acute hepatitis can also be caused by CMV. This tends to be more in neonates and immunocompromised people, and also EBV. So EBV is common in young people, but it also gives you other symptoms like massively, swollen lymph nodes, so swollen tonsils, and hepatosplenomegaly as well. Okay, and then you also have chronic hepatitis. So that's your Hep B, C, D, and E. And D is co-infection with B. Okay, so hepatitis B serology is a LabMed classic, and I think it's really important that you guys kind of understand this and you understand what each different marker means because it comes up all the time. So yeah, this is quite high yield. So starting off with surface antigen, this is the first marker to appear, and it normally implies acute disease. So acute disease is disease between 1 and 6 months, and if it's present for greater than 6 months, that implies chronic Hep B infection. So the presence of the surface antigen leads to the production of surface antibodies, and surface antibodies indicate immunity. So that can be either through being actually exposed to Hep B, or it can be if you're vaccinated against it, and the process of immunization has resulted in these antibodies. And these are negative in chronic disease. Then we have the core antibodies. These are only present if you actually get Hep B, not if you've been vaccinated against it. and they imply previous or current infection. And the IgG persists, whereas the IgM, the levels go up acutely and then drop down. Finally, Hep E antigen. That is from the breakdown of the core antigen from infected liver cells, and it's a marker of infectivity. So if you have a high level of E antigen, that means there's a high rate of viral replication and you're quite infectious. Okay, so now we're going to go through some cases of resolved infection, vaccinated individual, etc., and we'll talk through the different serology features. Okay, so surface antigen negative, core antibody positive, and surface antibody positive means that you've had previous infection, but it's resolved because you have surface antibodies, which means you don't have chronic infection. You have core antibodies, which mean you've actually had the virus, and you are surface antigen negative, which means that you currently don't have any replicating Hep B in your circulation. Okay, active infection. If you have active infection, you'll have surface antigen positive, you'll have core antibody positive, and you won't have any surface antibodies. So this means that the presence of the antigen indicates that the infection is still ongoing, and this is kind of reinforced by the lack of surface antibodies. And the core antibody indicates that you have actually been infected and it's not immunization. Yeah, and if you're thinking, is it acute or chronic, you can also check the IGs. So acute is high levels of IgM, chronic is IgG. Okay, and finally, moving on to vaccination. So in vaccination, everything will be negative except the surface antibody. So they'll be surface antibody positive, but they will be core antibody negative because they've never actually seen the virus. Okay, so now we're going to move on to non-viral liver disease, of which there are quite a few different causes. So the current main cause is non-alcoholic fatty liver disease, but it's not called that anymore. It's called MASLD, metabolic associated steatohepatitic liver dysfunction or something like that. And yeah, that's then followed by alcoholic liver disease. You also have various kind of rarer metabolic causes. So hemochromatosis is when you have iron overload. Wilson's, where you have copper overload, and that's like the classic Kaiser-Fleischer rings, which you'd see on slit lamp exam, which is a lab med classic. Alpha-1 antitrypsin deficiency as well. So if you see liver dysfunction and kind of lung dysfunction and like a kind of obstructive emphysema picture, you'd be thinking of alpha-1 antitrypsin, which is a genetic disease where you have too much of a protease. I think it breaks down elastin. Okay, so you also have other causes of non-viral liver disease, so PBC and PSC, which we'll talk about in a bit more detail, and autoimmune hepatitis as well. Okay, so PBC. PBC is commonly seen in middle-aged women, and it's autoimmune, and I feel like you guys probably know this, autoimmune diseases come in families. So if you have one of them, you're more likely to have other ones. So it's associated with other autoimmune diseases like Sjogren's and rheumatoid arthritis as well. And it's where you have chronic inflammation of the intrahepatic bile ducts. It has quite an insidious onset, and it's characterized by jaundice due to the elevated bilirubin and also itching due to the deposits of bile under the skin. And there's a gradual progression to cirrhosis and liver failure. So it's quite a serious condition that has to be treated. And you'd also have a raised ALP. And this is really important. So in PBC, you see anti-mitochondrial antibodies or AMAs. So if they do give you a question, it's like a middle-aged woman, they have jaundice and it's quite acute onset. They have itching as well. And they say that they have AMAs, then you'd immediately be thinking PBC. And yeah, there's not much else this could be. Okay, so on histology, you would have inflammation of the portal tracts. You'd also have injury to the bile ducts and granulomas as well as impaired flow of the bile. and also fibrosis of the liver. Okay, so moving on to PSC, this has a completely different demographic. So it's more common in young males from the ages of 20 to 40. And this is the one we talked about before because it has an association with UC. This also increases your risk of cholangiocarcinoma as well. So that's quite an important fact to remember. Okay, so in PSC, you have inflammation and fibrosis of the intra and extrahepatic bile ducts. And this typically presents with fatigue, itching, jaundice, and abdominal pain. So kind of a bit similar to the PBC. Okay, so it also has a raised ALP and also causes cirrhosis and eventually liver failure. However, it's not AMA positive, it's P-ANCAs you'll be looking for with PSC. And yeah, that's another fact, just remember. Okay, so the histology. So you'd have onion skin fibrosis around the bile ducts. You'd also have inflammation of your bile ducts and injuries, and the kind of chronic inflammation leads to the loss of the bile ducts as well as impaired flow of bile and fibrosis. So you wouldn't really do a biopsy for these conditions, so you'd want to diagnose them with an ERCP or an MRCP. So an MRCP is magnetic resonance cholangio, whereas this is endoscopic retrograde cholangiopancreatal. Yeah, it's quite a long name, but this is essentially like an imaging modality. So it's kind of like an MRI, and you can visualize the biliary tree, whereas this is more of an interventional procedure, which you use to remove the stones. And on ERCP or MRCP, you'd see a beaded appearance. Yeah, so these are kind of keywords that would lead you to think PSC. Okay, and here's a useful summary table that kind of differentiates the two conditions. Okay, so moving on to autoimmune hepatitis. So this is more common in females, and the majority of people with autoimmune hepatitis also have another autoimmune disease. So, like I said before, having one autoimmune disease increases your risk of other ones. And in autoimmune hepatitis, you'd be seeing ANAs and also anti-smooth muscle antibodies. So this is the kind of main giveaway in the question stem that it's autoimmune hepatitis. You'd also see other ones like anti-kidney / liver antibodies as well. Okay, so here is a question. You guys can have a read and then I'll talk through the answer. Okay, so the answer to this is Helicobacter pylori infection. So this is a bacterium that's present in the stomach and it massively increases your risk of gastritis and can lead to chronic inflammation, which leads to adenocarcinoma, and that's yeah, that's what is the answer to this question. And you can stain for it. The stain that you use to detect Helicobacter pylori is toluidine blue as well. So that's another thing to remember. Okay, next question. Okay, so looking at this presentation, the patient has severe abdominal pain. The pain is kind of central in the mid-epigastric region, and they also have a very raised serum lipase. So putting all these clinical findings together, you'd be thinking pancreatitis. So pancreatitis because the location of the pain and the raised serum lipase. They could have also given you raised amylase as well if they look for that as well. And which of the following lab tests? So the answer to this is hypercalcemia. So as I talked about before, the kind of causes of pancreatitis are I get smashed and elevated calcium and elevated triglycerides increase your risk of pancreatitis. So, yeah, the answer isn't hypercholesterolemia, which I feel like would be another one that people would commonly put down. So, yeah, it's triglycerides, not cholesterol, that increase your risk of pancreatitis. So, yeah, just bear that in mind. Okay, cool. So, yeah, that's what I just said. Okay, another question. Okay, so the answer to this is adenomatous polyposis coli. So the gene mutation responsible for this is the APC gene. And you need to know the difference between this familial adenomatous polyposis and Lynch syndrome or hereditary non-polyposis colon carcinoma syndrome. So I'll talk about that here. So they have different mutations. So the causative mutation for familial adenomatous polyposis is in the APC gene, but in Lynch syndrome, it's in the DNA mismatch repair genes, of which there are quite a few. And the clinical presentation does vary as well. So in FAP, you have many, many, many polyps, so over 100 polyps. And in hereditary HMPCC, you only have a few polyps present. So this tends to be a bit more low grade than this one. And this is a bit more common. And with FAP, this massively increases your lifetime risk of getting colon or like colonic or rectal cancer. So 100% of people with this gene mutation will eventually get um, colon or rectal cancer, but not every person with mutations in their mismatch repair genes will get colon cancer. And the location of the kind of affected areas also varies, and the age of onset as well. So you'd want to do a colonoscopy to kind of visualize the locations of these polyps and remove them to reduce the risk of progression and transformation into a malignant cancer as well.